Today, we will discuss surgical principles in the management of brain tumors. We'll have an overview of techniques and discuss the influence and the importance of technological advances. When we talk about brain tumors, it encompasses a large spectrum of lesions inside the cranial cavity. The first group are the actual brain tumors. They are the intraaxial tumors within the brain substance. Now, these tumors might be above the tentorium cerebelli, in which case they are called supratentorial tumors, or they may be below the tentorium, in which case they are called infratentorial tumors. These tumors may be benign or malignant. Malignant supratentorial tumors, the commonest are gliomas. Of these gliomas, astrocytomas dominate. They are graded from grade 1 to grade 4, depending upon the degree of malignancy. Grade 1, usually found in children. Classical example is a pilocytic astrocytoma. Grade 2 are low-grade gliomas. Grade 3 are anaplastic gliomas. And grade 4 is the horrible glioblastoma multiforme, where the average duration of survival after diagnosis with treatment is about 15 months. Metastatic tumors are also intraaxial tumors, and some infective intracranial space-occupying lesions mimic tumors like tuberculosis. Infratentorial tumors may be cerebellar, including metastasis and medulloblastomas, or they may be brainstem tumors. We are talking about intraaxial tumors. The commonest extraaxial brain tumors are meningiomas. Meningiomas usually arise from the arachnoid layer of the meninges. They are usually classified depending upon their location. Meningiomas over the convexity of the skull are called convexity meningiomas. Parasagittal meningiomas occur adjacent to the sagittal sinus. Parafalcine meningiomas are meningiomas which arise from the falx cerebri. Some meningiomas arise from the sphenoid wing. A lateral sphenoid wing meningioma is usually relatively easy to dissect, while medial sphenoid wing meningiomas may encompass the major vessels of the circle of Willis. Olfactory groove meningiomas occur on the anterior cranial fossa floor. Tentorial meningiomas arise from the tent. CP angle meningiomas arise from the cerebellopontine angle, and rarely we might have intraventricular meningiomas. Extraaxial tumors, extraaxial brain tumors, include tumors arising from the cranial nerves. We have vestibular schwannoma, which is the commonest. The older name for this was acoustic neuroma. The tumor arises from the 8th nerve complex. Trigeminal schwannomas are also relatively common. We also have optic nerve tumors. Epidermoid tumors may be present. Cellular supracellular region tumors are a different entity. These include pituitary adenomas and craniopharyngiomas. And then we have the ventricular tumors. Gliomas may be present. Choroid plexus tumors may occur, and meningiomas may also be there intraventricularly. The most important imaging modality is MR imaging. Each MR sequence has got a distinct value. T1 weighted images delineate the tumor. When we give contrast, it shows us the degree of breakdown of the blood-brain barrier. T2 weighted images show CSF as white, so vessels are very clearly seen. FLAIR or fluid attenuated inversion recovery images show peritumoral edema. Peritumoral edema is an indicator of brain invasion, which is a marker of malignancy. MRV, that is MR venography, is important especially in meningiomas when we want to study the flow through the sinuses. Functional MRI shows us cortical areas of eloquence, helps us in planning trajectories in deep tumors and in planning resections. Tractography is essential for trajectory planning. You want to reach a tumor, especially deep tumors, without damaging too many major tracts. Intraoperative MRI is useful, especially in some posterior fossa tumors and even in supratentorial tumors when you want to intraoperatively check the extent of tumor resection. The MRI has to be available inside the operation theater. CT scan has got role in many of the tumors, especially in meningiomas, when you want to see what is the degree of bone invasion. For example, in a olfactory groove meningioma, you want to see how much is the thickening of the anterior cranial fossa floor. Or in a sphenoid wing meningioma, you want to check as to how much is the involvement, because when you do an orbitozygomatic craniotomy, a highly thickened anterior cranial fossa floor might provide difficulties and danger. CT scan brain is also important in planning a craniotomy. Other accessory investigations include a perimetry, for example, in tumors where the optic apparatus is involved. A perimetry will show us the extent of field cuts. Audiometry is important for diagnosing acoustic neuromas or vestibular schwannomas. Hormone profile is mandatory when we are dealing with pituitary tumors. What are the principles of brain tumor resection? The primary principle is to remove the tumor with conservation of function. What are the approaches? You need a craniotomy usually to remove a brain tumor. The craniotomy may be a wide craniotomy or it may be a keyhole craniotomy. Sometimes people say in advertising that no craniotomy is required and a tumor can be removed through a keyhole. This is a misrepresentation of fact because the degree of bone removal depends upon the kind and the location of the tumor. Supraorbital keyhole craniotomy is useful for removing small tumors of the anterior skull base. Transnasal transsphenoidal approaches can be used for suprasellar tumors. Once we made an opening in the skull, the next is planning the trajectory. Of course, the opening in the skull has to be performed keeping the trajectory in mind. The trajectory is planned using neuronavigation intraoperatively, considering tractography as to where the tracts are located. Tumor resection is done either with a microscope or in the case of transsphenoidal approaches using an endoscope. There are some definite principles of meningioma surgery. When we try to remove a meningioma, the first step is to define the tumor. For that, you need the brain cortex to move away from the tumor. So that is the first step, de-dress the tumor. The second step is to devascularize the tumor because meningiomas are highly vascular and you have to attack the blood supply to the meningioma, which is from where the meningioma spouts into the cranial cavity. The third step is to debulk the tumor. Once a certain degree of devascularization is achieved, the interior of the tumor is debulked so that it becomes easier to deliver the tumor into the operative field without damaging other critical structures. And the final step is to dissect and to remove the tumor. Many adjuncts are useful. LP drain may help to remove the brain cortex or remove or retract the brain cortex from the tumor surface. In some cases, cerebrospinal fluid can be drained intraoperatively from one of the fissures or one of the cisterns. Preoperative embolization has a role in highly vascular tumors, but the risk is that it should not result in damage to the vessels which supply the optic nerve, for example, in anterior cranial fossa tumors. Postoperatively, meningioma patients require antiepileptics for a short period of time. Tumor removal is graded by Simpson grade. Grade 1 being a complete removal, including the involved dura, and grade 4 being only a biopsy. Radiotherapy is indicated in grade 3, that is malignant meningiomas, and in grade 2 tumors when there is some residual tumor. Intraaxial tumors like gliomas can be approached by a craniotomy. If there is significant peritumoral edema, a generous craniotomy is performed because even after tumor removal, there will be brain swelling, which has to be accommodated. In case there is no edema, a biopsy, which is a stereotactic biopsy, may be performed, or keyhole approaches, small approaches, can be used. How do we monitor the resection of a brain tumor? Intraaxial tumors merit some kind of monitoring. Awake craniotomy is one of the techniques where the patient is kept awake during surgery adjacent to eloquent cortex. By monitoring the patient's neurological function during the surgery, we can see when we are straying into eloquent cortex. Intraoperative fluorescence includes the use of a dye which can be seen by a special filter in the microscope. This will tell us as to how much and where the tumor extends. Navigation can give us an idea of how big the tumor is and whether we have reached the tumor limits. Intraoperative MRI can help us by showing if there is residual tumor. So in the operation theater, the MRI is done, and if there is residual tumor, the tumor can be resected. Post-op management of intraaxial tumors include anti-edema measures, anti-seizure medication. Radiation and chemotherapy is required for malignant tumors. Pituitary tumors are usually resected by endoscopic transsphenoidal technique. Small tumors are ideally resected by an extracapsular resection. Larger tumors, the tumor is entered and intratumoral decompression is done. It is very important to preserve the arachnoid because if you open the arachnoid, you'll have a CSF leak. The cranial fossa floor is reconstructed using fat, fascia, and fibrin glue and reinforced with a nasoseptal vascularized flap. CP angle tumors, commonest of which is the acoustic neuroma, will merit facial nerve monitoring and hearing monitoring in the case of small tumors, where hearing preservation is an aim. So in a final overview, the principle of glioma surgery is to achieve maximum cytoreduction with a minimum of deficit. Meningiomas are resected using the 4Ds: de-dress the tumor, devascularize the tumor, debulk the tumor, and then dissect the tumor. It is important to maintain the priority of maintaining quality of life because meningiomas are slow-growing tumors. Pituitary tumors, it is critical to prevent cerebrospinal fluid leaks. And the principles of keyhole surgery is to keep the skull opening as small as possible but as large as necessary. Trajectory planning through the brain is done with the help of tractography and neuronavigation. And the extent of resection can be maximized safely by using awake craniotomy, by using tumor fluorescence, and by intraoperative MRI.